Good evening, ladies and gentlemen. Thank you for joining us tonight. My name is Shane Simic, and I'm the marketing manager at Florida Hospital Tampa. On behalf of the hospital and our guest speakers from our Florida Hospital Physician Group, I would like to welcome each and every one of you to our Insuring Your Digestive Health seminar. Tonight, we're going to learn about digestive disorders of both the upper and lower GI tract, their common symptoms and complications, and some of the newest treatments available for patients. We have our two expert physicians, Dr. Arthi Sanjeevi and Dr. Sharona Ross. And after they speak, we'll then have our physicians be joined by Tina Solomon, our insurance specialist, and open up the floor to questions and answers related to digestive health and insurance troubleshooting to make sure that you can see the right specialist. We'll hold all questions until we get to that part of the evening. So if you have any questions that you want to make sure that you ask the doctors, please make sure to write that down in your notebook that we provided to you, along with any notes that you might want to be taking. Florida Hospital Tampa and our Florida Hospital Physician Group are committed to providing patients with a comprehensive range of groundbreaking, minimally invasive techniques to significantly improve all forms of digestive disorders, from the routine heartburn to the rare forms of cancer, and to educate our community about the proper management and treatment of those disorders so that families can become better informed and make the right healthcare decisions. And we're happy that each one of you have taken time to join us tonight so we can do just that. Our first speaker this evening is Dr. Arthi Sanjeevi, an advanced gastroenterologist and a native of India, who graduated from Madras Medical College in Chennai, India. She completed her residency in internal medicine at the University of Nebraska, a gastrointestinal fellowship at the Medical College of Wisconsin, and an advanced fellowship in therapeutic endoscopy at the University of Minnesota. Prior to her position here at Florida Hospital Tampa, she spent 4 years in academic GI at Virginia Commonwealth University and 3 years at the University of South Florida. Her specialty interests include pancreatic biliary disorders, GI oncology, GI motility, and small bowel pathology. Some of the procedures Dr. Sanjeevi offers through her practice, apart from the routine endoscopy procedures such as upper endoscopy and colonoscopies, include endoscopic ultrasounds, therapeutic ERCP, single balloon enteroscopy, and motility investigation using pH Bravo, manometry impedance, and breath tests. Please help me welcome Dr. Arthi Sanjeevi.
Thank you, Shin. Thank you very much for the very elaborate and accurate introduction. And you're really good in pronouncing all the difficult terminologies we have here. So we're actually going to be going back and forth today, and the focus is in your gut health, and we're going to go, I've called it the gut coaster. Being the summer, I'm not sure how many of you have been taking your kids and your grandkids to the busch gardens. I take them for their little nature fix and learn about different things, but all they want to do is do the roller coaster. So it is fun, and today you're going to be on a gut roller coaster. We're going to take you very quickly, starting at the mouth all the way, and get you out through the other end in a reasonable time today. So we're not going to stop at any station for too long, but if any of you have specific interest that you would like us to elaborate, we are more than happy and available to elaborate on a specific issue that you might like. So we're going to start with the entire reflux spectrum of disorder, and as I said, myself and Sharona will go back and forth on the medical and the surgical aspect, and we'll talk about gallbladder diseases, which is fairly common. We'll touch upon pancreatic disease, and we'll be open to talk about colon cancer screening, which everybody knows has to be done, but sometimes you wonder why me. So, gastroesophageal reflux disease. Now, we all talk about heartburn in an emotional sense, but medically, what does it mean? So, the consensus statement from Montreal, where a group of experts sat together and over good hors d'oeuvres like tonight, and they decided reflux of stomach content that causes either troublesome symptoms or complications is called gastroesophageal reflux disease. And All of us have heartburn once in a while. Now, is that a disease? So when is it a disease? If you have mild symptoms that occurs more than twice in a week, or if you have moderate to severe symptoms that occurs about once a week, then you probably do have gastroesophageal reflux disease. So your next question is, how common is this really, and what are the symptoms I should be feeling? Interestingly, about 20% of the Western population at some point or the other have experienced heartburn, while in the Asian population, it's only about 5% of the time they've complained of heartburn. Now, if you talk about the symptoms, most patients have direct esophageal specific symptoms, such as that burning you feel behind your chest, the reflux, which is the actual volume reflux coming up to the back of your throat. And sometimes if it's severe enough, you could also have swallowing difficulty. On the other hand, interestingly, there are people who may not viscerally perceive any of these symptoms, but they're having more of stomach symptoms like persistent nausea, particularly in the morning when you have a lot of reflux, a lack of appetite, which is new, and also feeling too full too soon. Well, previously you used to be able to enjoy a decent meal. And the other interesting aspect is there are another subset of population who may have only what we call the supraesophageal symptoms. And this group of people often land up in the ENT doctor's clinic, and for the longest time have not been recognized to have the origin of their problems as being reflux. And they would present with chronic sore throat, voice changes, or chronic cough. They're not able to quite identify why they have cough, or they may just have bronchial asthma, which is not responsive to the typical bronchodilators. And it takes a while before they are diagnosed with acid reflux. So, okay, so I've given you a fair description, so you think you do have this. What should you do about this? The primary thing we advise patients, which are good lifestyle suggestions for anyone, is to lose weight, because most kids, I mean, children may have reflux disease, but most people are not born with reflux. As you add more visceral fat, there is loss of the efficiency of the pinch valve mechanism, and people do tend to develop hiatal hernias as they get older, and there's also higher incidence of reflux, and there's a clear correlation with increasing visceral body fat. So losing weight may be one efficient way of reversing the reflux process if done early enough before the fixed hiatal hernia is established. The other things we usually tell patients is elevate the head end of your bed, and this does not mean just sprain your neck on 2-3 pillows. You actually have to elevate the head end of your bed with maybe a 6-inch cinder block, or you may need like a sleeping wedge that totally gets your waist to head up in an elevation, because there's a significant portion of the time you're horizontal, and if you don't have a good pinch valve mechanism, you're going to have back reflux. Also, you got to avoid foods that's going to aggravate your reflux. And what most commonly people think, it's not the spicy foods, but it's the alcohol. Things that are notorious for aggravating reflux are things that have caffeine, chocolate tea, coffee and tea, chocolate, alcohol, peppermints, going to a good pasta meal in Olive Garden and finishing off with a mint chocolate, perfect way to have a night full of reflux. So the other thing is to cut down on your alcohol consumption and smoking, which obviously does aggravate a lot of problems. The other thing one could do is eat a bunch of small meals rather than big meals that could possibly reflux, and also to wrap up a dinner early in the day, like if you're going to bed at 10, you may want to wrap up with your dinner by 6 o'clock. Late dinners are notorious for people who land up refluxing through their sleep. So you've done all this, it's not helping, you're still refluxing, and it's really diminishing the quality of life. You're not quite enjoying going out for dinners with your friends as before. So when is it time to seek medical help and just stop popping those purple pills you can now grab off the counter? So if your symptoms are severe enough and they've lasted long enough, and long enough I mean like 2 weeks, and you're still having heartburn and nothing is getting better, think of seeking care rather than sitting on it for many years. And if lifestyle modification and over-the-counter prescription did not help, which I mean, again, within 2-3 weeks, you're not turning the corner, it's time to think of seeking help. Another unique situation is we have identified there are certain groups of family which have a genetic predisposition for having complicated esophageal reflux disease. So if you do have family members who have complicated esophageal reflux disease, such as tendency to form strictures or cancers, you may want to talk to your doctor soon. So you've seen your primary care specialist and they put you on an acid suppression pill for happily ever after. Should you talk to them about, hey, maybe it's a time to see my gastroenterologist rather than take this pill for ever after? I think there is sometimes as consumers, requesting what you think you deserve is going to be very important. So these are the situations you may want to consider requesting for a specialist evaluation of what you otherwise think is just reflux. If someone you know or yourself are having trouble swallowing, or you feel that food is actually getting stuck, it is not normal. It is not normal for a person to typically get food stuck while eating dinner with a large group or or eating in a hurried way. So that is one red flag. And also if there is weight loss, or there's chest pain associated with these reflux, then the reflux problem may be substantially severe. The other situation is when there is choking and gagging. Those are the situations when people land up in the emergency room and then they say like, well, I've been choking and gagging, but I get over it, but this time I did not, so I'm in the emergency room. Waiting on this for many years, usually they already have irreversible damage in the esophagus, so waiting for a long time is not a good idea. And the other thing is having blood either in the vomit or seeing black stool, which is basically blood which under the influence of acid has become black in color. Those are the red flags where you need to seek immediate attention. So how is this investigated? We have a variety of modalities with which we look at the esophagus, not just one. The traditional way was to just do a barium swallow and to kind of look at the shape of the esophagus to kind of guess what could be going on. Increasingly, we believe in just going there and taking a direct look. Under sedation, it takes less than a minute for an endoscopist to go take a look to see directly what's going on in the esophagus. But several times in a patient with reflux, just a simple endoscopy is not going to answer the question because the damage is still not visible to the regular eye. So that is the situation where additional testing is done, and one of it is esophageal pH testing, and then we have the manometry impedance testing, and I'll show you some examples of those. So this is the traditional barium testing, which you can see that this is a normal esophagus, and this is a bit of an exaggerated mucosal ring that could develop in response to chronic acid reflux, and you see in this particular case there is a small hiatal hernia too. But when you look at this other esophagus, this person too had reflux for the longest time, but has a much more severe disorder, what we call an achalasia, which is an autoimmune disorder of the esophagus. At some point, there was an autoimmune type reaction which knocked off the ability of the lower esophageal sphincter to relax. So because of a chronic high tone condition, food has not been going through, and the rest of the esophagus is also kind of gotten dilated. And this esophagus literally looks like the colon from chronic stagnation of food. And the patient may not have had much more symptoms than just chronic reflux. And this is not reflux per se, but just stagnant food content rolling around in the esophagus. Now, I've thrown a lot of endoscopic images to give you an idea of how much information we get from just taking a look. So this is a nice, very beautiful esophagus. You see that pale pink esophageal mucosa, and this is a salmon color mucosa, which is the stomach, and this is a very neat lining. On the other hand, you can see that this person has been having long-standing acid reflux, and they're beginning to form a ring. And at times when they have this, and this is the hiatal hernia over there, and over here is where the diaphragm is, so there's like a 2 to 3 centimeter hernia and a mucosal ring, which can be the cause for food getting stuck in the esophagus and not going through. Now, this is a very unique condition that has been recognized more in the late 90s. It used to be called the asthma of the esophagus. We recognize this to be eosinophilic esophagitis. Symptoms may be very similar, just reflux disease, but these people tend to have more problems with food getting stuck in the esophagus. And this problem is primarily related to allergies to food or environmental allergens, and the acid reflux may be a secondary condition. Now, here is achalasia that I showed that the esophagus has gotten way dilated and there's so much of food stagnation. And this is a relatively older person who has difficulty in swallowing. And in this situation, you can see that they have a diverticulum or a little pocket that is developed in the esophagus because of this high pressure zone. As a result, they have food sitting in this pocket, difficulty in swallowing, and frequently these people complain of bad breath. So all these people just complain of difficulty in swallowing and reflux, but there could be a variety of pathology that is going on in the esophagus. And all these are benign. On the other hand, over here you see an example of a person with pretty severe esophagitis. These streaks are what we call esophageal ulceration, and this person has almost a grade D, which is a 4th stage of inflammation. If you let this go on for a long time, the esophagus learns to adapt around it. It goes through a adjustment, and we call that Barrett's metaplasia. The person may even start sensing acid reflux with much less severity. But the price you pay for this is it's a precancerous situation. And then given enough years, you could actually land up having esophageal cancer. So not everybody is meant to progress through this whole sequence, but some are. And the best way is to take a look and see what's going on in there rather than be in denial. So here are some of the testing that we do apart from just endoscopy. When the question is, if everything looks good, could something still be going on which is abnormal? And here is the Bravo capsule, which you can see is the size of a pencil tip. And by suction, it is perched on just 5 centimeters above the esophagus, and you carry a pager-like device for the rest of the day. There you can see the Bravo sitting in the esophagus. And I get very good data over the next 48 hours as to what is the frequency of your acid reflux. Is it worse in the daytime and the nighttime? Is it more after you eat? Is it in the morning or in the night? So we get a lot more data out of this than just a 5-minute look-see at the esophagus. So this is another study that we do when patients are awake. Sometimes it may just not be reflux, but the esophagus, the tube may not be pushing food down. And this is what we call an esophageal manometry. And we get this fancy topographic image. And this is a normal esophageal peristalsis that is swiping through the esophagus. You have a beautiful relaxation of the lower esophageal sphincter, and the tone comes back up again. Compare that with some of these abnormal ones. You can see that this patient is having long periods of relaxation of the esophagus with reflux coming up, and seems like they need 1 or 2 swallows to get things through. Over here you can see this person is having substantial amount of reflux going all the way up to the top of the esophagus, and this could be one of those patients who have asthma, chronic cough, voice changes. And here is a totally messed up esophagus, and this is a classic situation of achalasia. You can see that the sphincter is not relaxing at all because the inhibitory nerves have been hit. And then there's no peristalsis. It's just a uniform high-pressure zone, which is not really sending any food boluses down. And here is an example of a nutcracker esophagus. This is, again, an esophagus where there is esophageal spasm mid-esophagus, and the pressure is blasting through. And these patients may have a lot of chest pain. It's a lot of information acquired through proper investigative measures to give you a much better idea on physiologically what's going on in the esophagus, even if things are looking normal. I'm going to hand it over to my surgeon colleague, Dr. Ross.
One of the things I actually didn't realize the different symptoms. I always have food that gets stuck, and I just think it's because I took too big of bites. So I may be scheduling an appointment with you all later.
That's probably true, too.
Oh, that could be true as well.
Most men just bite and they then swallow, they don't chew.
This is true. Okay. I might schedule an appointment nonetheless. And on that note, before I introduce Dr. Ross, I did want to note Jenny Cooper, our practice director, and her team is in the back. You will be able to schedule appointments with either Dr. Sanjeevi or Dr. Ross before you leave tonight if you'd like to do so. Just wanted to call that out. So Dr. Ross is an advanced GI and HPB surgeon and a native of Israel. who, after serving in the Israel Defense Forces, moved to the U.S. and earned her medical degree from the George Washington University School of Medicine and Health Sciences in Washington, D.C. Dr. Ross completed her general surgery residency at the University of South Florida College of Medicine and was later awarded the prestigious HPB Advanced Gastrointestinal Surgery and Minimally Invasive Surgery Fellowship at USF Tampa General Hospital. She then completed an endoscopic gastroenterology fellowship at the Division of Digestive Disorders and Nutrition at the University of South Florida Department of Medicine. Dr. Ross is currently the Director of Minimally Invasive Surgery and Director of Surgical Endoscopy here at Florida Hospital Tampa, as well as the founder and director of the Florida Hospital Tampa Women in Surgery Initiative. Dr. Ross is also the director of the Advanced GI Fellowship Program at Florida Hospital Tampa and was one of the first surgeons in the United States to undertake laparoendoscopic single-site surgery. As a leader in American medicine, Dr. Ross continues to push the envelope in the advancement of minimally invasive surgery for the treatment of foregut and HPB disorders. Please help me welcome Dr. Sharona Ross.
Thank you very much, and good evening. So let's, just by definition, like Dr. Sanjeevi said, if you have about 2 or more episodes per week of heartburn, you have the diagnosis of GERD, and you should be evaluated by a gastroenterologist. But let's say you were diagnosed with GERD, you were evaluated, before you were evaluated, but you know that you need to do and go through all the, lifestyle modifications, and you started to exercise, you stopped smoking, you lost about 30, 40, 50 pounds, you're now BMI of 26, and your symptoms are not better. So you go to Dr. Sanjeevi and you get evaluated, and indeed you have GERD, now by objective studies, and medications can help, like the proton pump inhibitor that everybody's on, Protonix or Omeprazole, Nexium, Prilosec, they're all out there. Well, they were approved by the FDA for 2 weeks of treatment about 20 or more years ago. But now we know about many side effects from those medications. So as GI physicians, we no longer recommend to be on those medications lifelong. Something needs to be done, and that's why you're all here, and hopefully listening to what we're trying to alert you from is reflux is an epidemic almost. And people are just putting themselves on medication and think that they're being treated. Well, they're not. And so when everything is diagnosed and all the evaluations have been done and you were told that you have reflux, then when do you need to come for an operation? Well, just by having the diagnosis, you went and met with Dr. Sanjeevi. She said, you have GERD. And the symptoms with medications help you. You should still look into surgery. If the symptoms don't help you, but you know by Bravo pH that you heard here, which is that probe that she places in the end of the esophagus, that is the only objective study that really documents how many times you have acid reflux into your esophagus, how acidic that fluid is, and how long does it stay bathing the lining of your esophagus, because it gives us a Demister score. And we know it's very simple. If the Demister score is about 14.7 or higher, you have reflux. So forget the symptoms. We don't even only rely on the symptoms. If you have reflux, even if the symptoms are not improved by medication, you should come to be evaluated by a surgeon. If you have esophagitis, and we know it's as a result of acid reflux, you should be treated. It's a mechanical problem, as you know, as she described, that the sphincter is always relaxed. It's a mechanical problem that needs to be corrected mechanically. Demister score, as I mentioned, is another indication. So what are some of the treatments? Dr. Sanjeevi mentioned acid reflux. Well, we have all kind of endoluminal treatments today, which means no incision, making no incision on the abdominal wall. One of them is the transoral incisionless fundoplication, or TIF. Another name is esophax. That's the name of the device. And what we do with that, as I'll show you in a second in a clip, is we placing a device that then, as you see here, it's going to go into the stomach, through the mouth, and what we do is we make a wrap from inside your stomach, and we enhance that sphincter in such a way that it will be tight enough to prevent acid from refluxing up into the esophagus. And that's a great advancement. Now, and as you'll see in a second, we used to have to do a big operation, big incision to do very similar fundoplication or wrap. Now, why not everybody are candidates for this procedure? Because it has to be a very specific indication. You cannot have a hiatal hernia greater than 2 centimeters. And you have to have acid reflux, right? And so one of those, if you have a hiatal hernia that is greater than 2 centimeters, you're already not a candidate for this. So that's why not everybody that comes through our door and comes to our clinic cannot have this necessarily. But we evaluate everyone for this kind of procedure. This is just to show you how it used to be in the past, and when just before PPI came out, the medication, the miracle drug, and everybody had, usually the incision is up and down, but that's the only picture I found. And so it's up and down incision, big operation, retracting all the skin and the ribs and everything just to get into the esophagus area and the upper stomach and do the wrap. Big operation, big morbidity, long length of stay in the hospital. It's a big deal. Then we started to do it all through a smaller incision, what we call conventional laparoscopy. And as you heard before, we started in 2007 to do it all through a 1.2 centimeter incision inside your umbilicus, your belly button. So we leave you, once it's healed, with no new scar other than what you were born with. So that's by embracing technology, we're able to offer you that with an operation for the treatment of reflux. So this is just to show you that, trust me, it was very hard not to bring surgical videos here, but we're trying to use just animation, so you're able to tolerate, your dinner and not having to go to the bathroom just to. But this is the animation, what exactly is happening. That's how we wrap the stomach around the esophagus, increasing the pressure here, preventing acid from coming up into the esophagus. But you see the size of this incision. Then we developed the conventional laparoscopy, which has smaller incision around the abdomen. So you have here 5 different incisions. Well, by embracing technology and minimizing the size of the scope and the instruments, we're able to do it all through the belly button. And it's the same exact operation, which I'll show you also in animation, but for a different operation, but it's the same concept. And this is how we do it, and I'm not showing the video, but this is the belly button. Those are the ports that allow us to deliver those instruments right into your abdomen. And this is how it ends up looking after the operation once you're completely healed. It looks like a normal belly button. Now, Dr. Sanjeevi mentioned esophageal cancer. It's almost like an epidemic now with esophageal cancer. We used to see very few, and it used to be majority was squamous cell carcinoma. For people that smoke and drink alcohol, they get squamous cell carcinoma. But now the numbers of adenocarcinoma of the esophagus are really on the rise because so many people are suffering from reflux and they're being treated for the past 20 years or so with PPIs. So what you do, you're not stopping the disease, you're slowing down the progression, but still it is progressing. So those that will end up developing Barrett's, so it starts esophagitis, Barrett's to dysplasia, mild, moderate to severe, and then you have cancer. So I can't tell you how many patients have come through our clinic saying, for 30 years I've been suffering from reflux, and I followed all the direction. I took twice a day, I took PPIs, and I got scoped every year, and literally the disease was watched, and now they have esophageal cancer, which is that operation that will, again, it's a really nice operation, but you don't want to have this operation. You want to prevent this from happening. So normally we used to make a big incision here and a big incision in the chest. Now we do it here. My partner and I are doing it all robotically. This looks like a big port, but it's the same size incision. It just has a wound protector. That's how we extract the specimen, which is the entire esophagus and the top of the stomach, and we extract it through that little incision here, which is the same. It's about 1.5 centimeter incision right over here. very small. And then we make another incision here in the neck, and we make the dissection of the esophagus right from the neck and through those ports. And with the robot, we dissect the esophagus by seeing everything avoiding the chest, avoiding the lungs and all those spaces. We're able to dissect all the way through the mediastinum without entering into the chest, no chest tubes, just smaller incision here. Then we bring the stomach up into the neck and reconnect it. It is incredible. Patients do great. They barely, if any, spend time in the ICU. This is by embracing innovation. And you won't find it in many places, but what I do want to emphasize is you don't want to be in this point of the disease. Dr. Sanjeevi, we'll move on to the next disease.
That was very impressive, wasn't it? Technology is something unique. So we have to move on to the next location in the stomach. So I'm going to give you a broad description of the region below your esophagus. And this area is a thicket of very important structures. So that's why when somebody describes bellyache, it's not very easy to pinpoint what is exactly going on. Can I take this out? Okay. I'm a walk-around talker. So you can see that the esophagus brings the food to the stomach, and then the stomach takes the food in a sweep down the duodenum. The C-shaped structure is the very first portion of your small bowel, which is the duodenum. And this is a very critical area because there is a meeting point of several organs. Now, here is the big, massive liver, which has very many important functions, and part of it is also secreting bile, which is collected in your biliary ducts in the gallbladder. And after a meal, the gallbladder pumps the bile into the small bowel, which is combined with the pancreatic juices. Now, the pancreas is a very enigmatic, very interesting organ for multiple reasons. It has some very important functions, which I will talk to you about shortly. But if it turns on itself, it can cause some pretty bad complications too. So the pancreatic juices and the bile combine and open into a tiny little pore in the duodenum, and that helps with the digestion of food. So when someone is complaining of pain in the right upper quadrant, there could be issues related to the stomach, the liver, the gallbladder, the bile duct, the pancreas, the duodenum. We're not quite sure what exactly is going on. So here is just a map of where all you could be hurting. So esophageal pain could be in your chest. Now, gallbladder pain can be in this location, but you could also hurt up in your shoulder. And also there are GI-related organs that can cause pain in this region, like the kidney, like the urinary bladder. And someone who thinks they have abdominal pain the whole time may have a bad back too, which is causing a pinched nerve. So any kind of abdominal pain definitely requires a careful step-by-step evaluation of what is going on in the belly. We're not going to have time to talk about every possible cause of abdominal pain, but typically most people think, well, my belly is aching, maybe I have a gallbladder disease because my aunt, right about my age, had her gallbladder taken off. So let's educate ourselves about what is about gallbladder disease. Now, this is a very common problem, and in this country alone, about 6.3 million men and 6.3 million men and more women between the age of 20 to 74 have gallbladder disease. The prevalence ranges from about 8 to 26 in the Hispanic Americans, and it can be even as high as 7 to 3% in the Pima Indian women have gallstones. By the age they are even 25, 3/4 of the women have gallstone. So what are the risk factors for gallstone? The typical medical student description is the fat, fertile women of 40 have gallstones. Does hold good, does hold true to a large extent. Age is associated with gallstone disease. Women definitely have more instances of gallstone disease, and pregnancy is a very high risk period. What happens is estrogen makes you secrete more cholesterol, while on the other hand, the progesterone reduces your bile acid secretion, and it also makes the gallbladder not function so actively. So pregnancy is a risky phase for making gallstone disease, and if they escape that period, again, closer to 40, women do have a higher incidence of making stones. And the other situation is one of those gung-ho rapid weight loss procedure measures to lose weight too rapidly, more than 1 or 2 pounds per week, does precipitate a gallstone attack in many people. Genetics does play a very important role. As I said, as a Native Americans in the Pima Indians, we don't know what's going on, that most of them land up making gallstones. Certain medications, but also certain population, like people with cirrhosis, with hemolytic anemia, and those with Crohn's disease, have very high instance of having gallstone disease. So you might ask, like, so how do I protect myself from having a gallstone disease? If you already have it, it is there. But if you don't, some of the things you can do is increase your vegetable protein consumption. Poly and monounsaturated fatty acids, which is typically found in your EVO, can help with reduce your risk of gallstone disease. Vitamin E, cholesterol-lowering medications like statin. And interestingly, there is a study that also says that people who drink a lot of coffee have reduced incidence of gallstone compared to those who have less consumption. So what are the symptoms that you would experience? Typically, it's a colicky kind of a pain in the right upper abdomen after a meal, particularly if it has any amount of fat. But also there may be some atypical symptoms like a lot of nausea after the meal, excess sweating. You may also just have a feeling of early satiety and feeling too full. And as I said, when an acute gallbladder attack can irritate the diaphragm, and irritation of the diaphragmatic nerve can actually radiate to the right shoulder. So those are the things to watch for. So for some people, the gallbladder problem may be a slow festering issue. On the other hand, it could precipitate very quickly with no prodromal symptoms for weeks or months. And this could be in the form of fever, guarding, and jaundice. And if any of this happens, it could be a life-threatening emergency, and attention is required right away. When it comes to investigating what's going on in the gallbladder, most typically we start with an abdominal ultrasound examination. And if you have all the typical symptoms of gallbladder disease, but the ultrasound is not really showing any form of gallbladder stones or sludge, which is basically crushed stones, which are muddy sediment in the gallbladder. If neither is there, your doctor might suggest you go through a HIDA scan, which is basically a functional study, where you see if the gallbladder is functionally able to pump the bile out of itself. So if it's not functioning well, it's called a gallbladder dyskinesia. Some other tests that might be considered would be something like an MRCP to see if there's any stones in the bile duct. And in more complicated situations, such as when there is jaundice or when there is a question if there is a stone in the bile duct, before going through surgery, there may be a need to have endoscopic evaluation to make sure the stone did not pop out of the gallbladder and it's stuck somewhere in the bile duct, because that would be a risk for having a severe pancreatitis. And those studies would be endoscopic ultrasound or the ERCP with some additional investigations such as the sphincter of Oddi manometry. People do always ask, so now I have gallstones, what is the medicine I can take to melt this away? There isn't really any promising medical therapy for gallstones which are already there. So symptomatic gallbladder disease, pretty much you are headed for a surgery, but not everybody with gallstone needs to have surgery, but those with symptomatic gallstones probably are better off having the gallbladder taken off, and you can totally have a normal, regular life without the gallbladder there. So symptomatic gallstones, when an acute precipitating attack of cholecystitis happen, or there is a chronic festering gallbladder inflammation. The other situation where you may not be that symptomatic but still warrants a surgery is biliary dyskinesia, where you have the typical gallbladder type of pain, but investigations do not show a frank sludge or a stone in the gallbladder. And the other unique problem is when you're totally asymptomatic, but by some lucky break, you landed up getting an ultrasound for some reason and a gallbladder polyp is found. Now, these small polyps are okay, but once it's over a centimeter, there is a high incidence of that possibly turning into a cancer in your lifetime. And being a dispensable organ, I think it's perfectly valid to consider an elective cholecystectomy for that. And I'm going to call upon my very able colleague, Dr. Sharon Ross, to talk more about the details of their very aesthetically pleasing gallbladder surgeries.
Thank you. So we talked of when you want to be evaluated for surgery for reflux. Well, for gallbladder disease, the time that you really want to be evaluated is before you had cholecystitis, acute cholecystitis, which is acute inflammation of the gallbladder. That means you had more than one attacks or you had one bad attack, because that makes the operation a lot harder. Well, you definitely don't want to come when it's acute on chronic. That means you have so many chronic attacks. Now the wall is all scarred down. It's not just inflamed because it's acute, but it's also very scarred down. Much more difficult to take it out. Biliary dyskinesia is great if you just have that and you come to be evaluated for an operation, or symptomatic cholelithiasis or gallstones. But with the first attack, and trust me, if you had an attack of gallbladder pain, you can't forget it. It's just severe. It stays there for hours, and it starts about 30 minutes to like 2 hours after fatty food. I did smell as I came here there was something fried here. And so if you get in the next 30 minutes to 2 hours an attack, okay, that was intentional. So right upper quadrant goes to the back, and it stays there for a long time, a lot longer than you would like. And sometimes if it's for dinner, then it comes in the middle of the night, wakes you up, and it stays there for a long time. That's the kind of pain that gallbladder would cause you. And you want to come with after the first attack. The more attacks you have, the sicker the gallbladder. From a simple operation, it can go to a very big operation. So what is the operation? So first of all, like we mentioned before, we do all of our, my partner and I, all of our laparoscopic operation through a single incision, and that's what we call LESS. LESS stands for laparoendoscopic single site surgery. So it's a less cholecystectomy, it's a less Nissen fundoplication, it's a less hepatectomy, pancreatectomy, whatever it is, single incision laparoscopic case. So that's a less cholecystectomy, which is removal of the gallbladder. What does it mean? It's scarless. You're not making any new scars. But it also means that it's not just about having no scar, but if you have less incisions, you'll have less pain, right? And especially when you have those incisions by the rib cage, because the rib cage is the periosteum full of nerves. And so if you have a port there and it's constantly putting pressure on those ribs, that causes a lot of pain later on. So by putting it in the belly button, you really save yourself from a great deal of pain. Faster return to normal activities. Patient, like I would want, an elegant operation, and if I have an elegant operation, that must be an elegant surgeon. So I would like to be considered an elegant surgeon, and I know you would want an elegant operation. So we can work together. Now, cholecystectomy, we started, my partner and I, to develop that with a handful of surgeons from the country back in 2007. And why did we start with cholecystectomy? It's a relatively simple operation. It's very common. It's the most common operation in the US, cholecystectomy, or removal of the gallbladder. It doesn't, there's no reconstruction. You don't have to put like the bowel, small bowel into the stomach, or no reconnection. So it's a simple operation. You take the organ out and you're done. And so there are not too many moving parts. So that's why it's very useful. We can get very good with that and that technique, and then take it and apply it to more complicated techniques. When we reached the 500 less cholecystectomies, we wrote a paper to show everyone in the community, because we collect all of our data. And we really collect the data in order to better our outcomes. So if you look at how our patients are doing, you know what needs to be better, and you know how to improve it because you see what's not going well. And so we are absolutely, if you come to our practice, you will have to fill up a questionnaire about how you are doing before surgery and after surgery. And then we improve it, and that's how we grow. And so with 500, after we did the 500, we realized that this operation is, number one, safe. Number two is very efficient. You can do the same operations you would do with multiple incision, but with less pain, great length of stay, which is less than a day, obviously, and patients do well. And they like not having scars at the end of the day, if they can, as long as it's safe. Also, like I mentioned before, we embrace technology. So we use different multi-trocars ports at the belly button that allows us to do different operation, different extraction. In this situation, we use this specific port because there's a sleeve here that protects the abdominal wall as we take the gallbladder out. And so that is very unique. We also use very small scope that has a deflectable tip. So from the belly button, we can reach to all different quadrants of the abdominal cavity, which makes it very nice, and we don't need a big incision for that. This is just a clip again of animation that we put together to standardize the single incision cholecystectomy. And this is just to show you the toolbox. By the way, this animation was done in Europe, and they had all the surgeons were men, and the nurses were female, were women. And so obviously you'll see now everybody is a woman, because I said if you're putting the men as the only surgeon, I'm not talking about this animation. So I'm not going to present that. So now you see they put everyone as women, which I accept. And so so you see here what you see through those 4 ports, and that's the animation we use to train other surgeons. What needs to be done, what instrument to put through which hole in order to have the same exposure as you would do with 4 separate incisions. And you do a safe operation, the same principles of laparoscopy holds here, and you do it nicely, bring it out to the belly button, and patients love the outcome. So this is just dissecting the cystic duct and artery, and then this is obviously the gallbladder that is being retracted. This is the liver, and it's completely attached to the liver, and that's when things can go wrong. If you cut the common bile duct, it goes from a very simple operation in the belly, a small little opening in the belly button, to a big operation where you need to reconstruct the common bile duct, which drain the entire liver. That's where the bile is draining through. So that's why it's very important to go to the right people to do your operation, any operation. So then we push the envelope even more. Now we're offering this operation. If you don't want general anesthesia, we do this under epidural, and we can do it really safely. You can choose to watch your operation, you can listen to music, or you can ask to go to sleep, but you're not paralyzed. Let me say this again, you're not paralyzed. And what was shocking, because we study our outcomes, and we prospectively randomized our patient. One arm had a single incision with cholecystectomy with general anesthesia, and the other with epidural. And to our surprise, one of the things that we found is that in the first post-operative day, the first 24 hours, because people do well with laparoscopy, period. But the first post-operative day, patient had significantly less pain. In fact, we did, one of them was at 7:30 in the morning, at 11, she picked up her daughter. I mean, wow, this is a big operation. I mean, big operation, not much to show. It's a small incision, but it's not a small operation. It's right by the liver. Okay, so epidural seems to be the key to really have great improvement with this type of operation. Now, not everybody can have epidural because for whatever contraindication that you have, may have problems in the spine. If you take Plavix and all other anticoagulation, anesthesiologists will be reluctant to give you epidural. But it applies to everybody else that does not have those specific contraindication. And it's surprisingly less expensive because all those gas for anesthesia is a lot more expensive than just using the lidocaine in the epidural. Cost in the operating room is less. No induction of anesthesia, no extubation. In the PACU, in the SPU, everywhere it's less. So when we did the study, we noticed that it cost you less with epidural. But we haven't caught up to really now, the next study that we have, we're again randomizing a larger group of people. This was just 20, 10 and 10. A larger group of people to exactly look at the cost. Even the cost of how much narcotics they would need after surgery, because that costs a lot of money. So we're looking into more and more, not just good health care, but how can we reduce your cost? Next is the pancreas.
So Dr. Ross was just saying, I love the pancreas, and we do because it's one organ that demands a lot of your respect because it's a very unique organ compared to any other organ in your body, because if any other organ has a dysfunction, it just has a dysfunction, it doesn't work, and it gives you trouble. But this one can can cause a lot of havoc. It comes at you with a vengeance, and so you want to give it its due respect. And the reason is because the pancreas has some very important function, and it has both endocrine function, which is secreting the insulin, and the glucagon, among few other important hormones too. But these two are key hormones in maintaining your blood sugar balance, and if they're off balance, a person can become diabetic. And also another very important function of the pancreas, it's what we call the exocrine function, or its digestive function. And this is the organ that is responsible for secreting all the proteolytic enzymes and the enzymes to digest all the food that comes through your stomach. But what happens when these juices are not permitted to flow through the beautiful pancreatic ducts, through the opening into the gut? All these enzymes are turned on itself, which starts off an autodigestive process, and it can spill all over the gut and cause digestion of the rest of your body. So pancreatitis could become very severe and life-threatening in a very short period of time. So this is an organ that we believe has to be handled with a lot of care, and you would, if any pancreatic-related health issues do happen, they definitely need to be handled in a tertiary care facility where the physicians and the surgeons have the focus and the interest and long-standing experience in dealing with pancreatic disorders. So it's not going to be within the scope of today's getting together to talk about the details of all disorders of the pancreas, but I'm going to paint some broad strokes. You saw the picture of health in the previous image, and this is a picture of a very diseased pancreas, and a lot of issues can go on with the pancreas. Now, inflammation of the pancreas could present as a severe acute pancreatitis. Patients may have recurrent attacks of acute pancreatitis, and it could morph into chronic inflammation of the pancreas, where now more than inflammation, there is a lot of calcification, scar tissue formation, now that the organ is less inflamed, but also more scarified, and it's functioning at a lesser capacity. Now, all of these conditions that I've enumerated here have a significant overlap. Now, once a person has chronic pancreatitis, it could lead to pancreatic insufficiency. And when you talk about pancreatic insufficiency, it could be both endocrine insufficiency and inability to digest the food, which is the exocrine insufficiency. So someone who has a sudden onset of diabetes for no explainable reasons, we do suggest that think if something is going on in the pancreas, if there's been no other explainable cause like weight gain or a slow increase in your blood sugar level over time. Now, this is talking about inflammatory conditions of the pancreas. On the other hand, there are also tumors of the pancreas that can happen. When a pancreas has been chronically inflamed, there is an increased risk of having cancer in the pancreas, but cancers of the pancreas can also arise de novo. There are bubbles that can occur anywhere in your body, in your liver, in your kidney, and most of the time when you have a random CAT scan obtained because of a back sprain or a kidney stone, if you have a cyst in your liver or your pancreas, it's just going to be blown off as, yeah, you were just born with a manufacturing defect. But the pancreatic cysts get a lot more respect in regards to needing more evaluation, because half of them do tend to be benign that probably do not need any major intervention. But the other half, even if not frankly malignant, may have a potential to become a tumor in the future. So that's when a referral to not just a regular gastroenterologist, to someone who has special interest in the pancreas may be essential, because that might be a time in more pancreas-specific endoscopic investigations maybe need to be performed to investigate if these bubbles in the pancreas or these cysts have malignant potential, or are these just benign potential, and do you need to just be watched over time, or do you need to be channeled to a surgeon for further care? And of course, I threw in the worst case scenario is the very bad pancreatic cancer, but not all pancreatic cancers are really the adenocarcinoma, in which case we say that the prognosis is pretty bad. There are some other tumors of the pancreas which potentially could be curative and maybe not as bad as you assume. So even when it comes to tumors of the pancreas, they definitely need a tertiary care evaluation to figure out how we are going to potentially seek for cure and prolong life if this is something that is not going to be curable. So leading causes of pancreatic disease, again, the most common cause of pancreatic disease is excess alcohol consumption. And the second leading cause is gallstone disease, because if you remember the anatomy that I showed a few slides ago, you can see over here that there is a common channel. In most people, 90% of the people, the common bile duct joins with the main pancreatic duct, and they open into a very tiny pore in the duodenum. So sometimes when they have chronic sludge and tiny stones coming down the bile duct, it can plug up this area, and this plugging of the opening can cause all the digestive disease to backwash into the pancreas and cause pancreatitis. So, so that being the two leading causes of pancreatic disease, there are also some rarer causes of pancreatitis. There is a well-known condition called hereditary pancreatitis, which has a very high association with subsequently developing pancreatic cancer. Congenital disorders like cystic fibrosis, some congenital anomalies in the structure of the pancreas can potentially cause pancreatitis. Also, more rare cause of pancreatitis are autoimmune pancreatitis and tumors which are causing sort of a roadblock to the pancreatic duct and secondarily causing pancreatitis. So the symptoms when it comes to the pancreas could be very severe abdominal pain that is radiating to the spine, and also symptoms related to pancreatic insufficiency might be present when it's morphing into more of a chronic pancreatitis, such as malabsorption and diarrhea due to lack of the enzymes that can lead to weight loss. And also, as I mentioned, if someone for unknown reasons suddenly becomes diabetic, we do encourage think of possible problems with the pancreas. And the other thing is when the pancreatic head is very inflamed, it can actually cause obstruction of the food to get out of the stomach and causing direct obstruction of the gastric outflow, and the person may present with nausea and vomiting. So the primary investigation starts with doing a few labs. The doctor might order some amylase, lipase, look at the liver function test, do some stool tests to see if there's any fat. But most of the time, we rely on imaging studies to take a look at the pancreas, and we need a good quality imaging, not any regular CAT scan, but we want a good pancreatic protocol CAT scan. And also MRI directed towards the pancreas may help give us a good idea on what's going on with the pancreas. Having done this, when more answers are required, this is when you need an advanced therapeutic endoscopist to do further diagnostic investigations on the pancreas. And we do procedures such as the ERCP and the endoscopic ultrasound. And to just give you a description of what this is the tiny little pore through which the common bile duct and the pancreatic duct open up. And it takes a lot of skill and technique to get into this tiny little pores, to get into this duct. This is the bile duct, and this is the liver, and you can see that this gallbladder is filled with stones over here. So, and on the other hand, you can see that the pancreatic duct looks pretty normal. Now, on the other hand, if you're suspecting a mass on the pancreas, here is an ultrasound, which also is like the ERCP scope, but it has the additional ability to ultrasound right around the circumference of the gut, and the pancreas wraps around the back of the stomach. So it's a great tool to look at the pancreas with a lot of resolution that you do not get with even the regular imaging studies. So you can see over here that a person has a mass in the mid-body of the pancreas, and the endoscopic ultrasound from the stomach is able to pick up on this lesion, which is barely 1.5 centimeters, and through needle biopsies, we are able to obtain tissue to identify what kind of tumor that could be. So we are able to guide the surgeon before the surgery, even to get a hint of what kind of malignant potential this is there any local spread. We stage the disease and then subsequently refer to our pancreatobiliary surgeons, Dr. Ross and Dr. Orsmegi, to see what would be the optimal surgery for this patient. You can see that over here is a patient with slightly bigger mass in the pancreas, and this is the ultrasound needle, real-time taking biopsy of the pancreatic mass. Okay, thank you.
So from all of these slides, only one slide for surgery. So pancreatic cancer is not a good diagnosis to have, but when you do, cure is resection. Yes, we do have chemotherapy, but really to be cured from this disease is resection. This is just to show you if you get pancreatic cancer in the head of the pancreas, so if you think about the pancreas, this is the entire pancreas. You have the tail, body, and head. If the mass or the lesion is at the head of the pancreas, as Dr. Sanjeevi showed you before, there is the ampulla where the common bile duct, which is that green structure, drains, and the pancreatic drain through the same opening. It doesn't take a big mass to obstruct that opening. That's when people present with painless jaundice. They turn yellow, and neighbors would say, "Oh, you're yellow." And that's what gets them to the primary physician. This is a relatively rare disease, but we find more and more cancer now in the pancreas because of CT scans. We do CTs for all different disorders, and suddenly there's something in the pancreas. And so people are very aware of the pancreas because of the CT scans. And so now we find them all over the pancreas, and there's different procedures, surgeries that we do for the tail or body of the pancreas, which is removing that part of the pancreas with the spleen that is sharing blood supplies. So the spleen and the body and tail would be removed, and patients do very well. No reconstruction. However, for the head of the pancreas, in order to remove this lesion, the head has to come out. And the head shares blood supply with the duodenum. So you have the esophagus will come down, then you have the stomach, which is right in here, and then you have the duodenum, which is the first portion of the small bowel. Then you have the jejunum and the ileum, right? So the duodenum is it's hugging the pancreas, and that shares blood supply. So in order to remove the head, we have to remove the duodenum as well. But if we remove the duodenum, then we have to divide the stomach right here, pretty much just past the stomach. So it's the first portion of the duodenum. We have to we take the gallbladder out with the specimen, so we cut the common bile duct that drains the liver over here, and then we have to cut this bowel, which is the jejunum. This is duodenum. If you cut this, you have to remove the whole segment. So you divide it here, and then what you have to do, and then you obviously divide the pancreas here. So in other words, now you have the stomach is open, the common bile duct is open, and the pancreatic duct needs to be drained into something because you left the body and tail. So this is the reconstruction that we do. So now instead of everything being connected to the first portion of the small bowel, we take the second portion, we bring it up, and we connect it to the pancreas, we connect it to the stomach, and then we connect it to the common bile duct. So now everything is connected to the second portion. So once you are healed from this operation, which is a big operation, we usually require a big incision. It's a big operation, long reconstruction, but now we can do it with the robot, which allows us to make smaller incisions and really do a nice job with three-dimension articulation. It's nice, and it decreases length of stay in the hospital. But this is what happens, and then when you heal, everything is back to normal, because all you change is the drainage. Instead of the first portion goes to the second portion. So it used to be a big, frightening operation, but now we do a lot of them. We do over 5 Whipples, this is the name of this operation, a week, if you can imagine, because we became a center for pancreatic cancer and reflux. And so that's why we see this a lot. And so we can do it today with minimally invasive approaches depending on the size of the tumor, because that usually involves major blood vessels and all that. So we will offer you the safest approach, but just so you know, you can have it now robotically. Hopefully you won't need to have it, but if you do, at least you can do it minimally invasive and you recover a lot faster.
But we are coming to our last station now, colon cancer screening. Everybody knows about screening colonoscopies. It's not one of those obscure things. But let's look at some facts. This is the second leading cause of cancer-related death. And 600,000 people, that's a typo, it's worldwide, die from colorectal cancer every year. What is your lifetime risk of getting colon cancer? It's about 5%. And 90% of these colorectal cancers seem to happen after the age of 50, and that is why the task force and the ACG and the AGA have come up with the recommendation that 50 is the age that you need your first screening colonoscopy. Now, the interesting fact is, as common as redundant as you have heard the word colonoscopy, only 65% of eligible adults who need to go through colon cancer screening actually are going through colon cancer screening in this country. Some of the facts to understand and to tell your friends who do not believe in getting themselves screened is one of the prevailing, beyond the embarrassment of going through the whole procedure, one of the things you hear is like, well, what is meant to happen has happened. Who can prevent a death from a cancer? Now we have the evidence that colon cancer screening on a 30-year follow-up has actually proven to not only remove colon polyps, but to actually reduce mortality related to colon cancer deaths. So in this country, we're actually on a decline in deaths related to colon cancer. And even if someone has a one-time screening, a half evaluation, which is a flexible sigmoidoscopy, there seems to be a 23% decrease in the incidence of colorectal cancer. So why die of embarrassment? This is something that everybody should undergo, and they should definitely recommend their friends, and people have reservations about going through with the process to have it removed. This is a cartoon that is showing the progression from a tiny little polyp that is found on the surface of the mucosa, which slowly starts infiltrating into the deeper muscle layers to now involve the lymph nodes and the surrounding blood vessels. And once that happens, it's only a matter of time. It's carried to this distant organ. But this process doesn't happen very fast. It takes its time, and usually it starts in the size of this little polyp, which can easily be plucked off, while if it's allowed to grow over time, it can become a complete cancer. So why not make use of the window of opportunity to knock it off when it's this small? So there are several tests. If you look at the task forces, they recommend a FlegSig every 5 years, which is looking at the left half of your colon. My concerns with this is it does not look at the right side of the colon, and they're particularly in women, the incidence of right-sided colon cancer is definitely higher. So as most gastroenterologists, I would also recommend colonoscopy as the first option of choice, because not only you get to see these polyps, you also knock them off at the same time. There are other modalities that you could go through, which is the air contrast barium enema or the CT colonography, which is recommended every 5 years if your insurance approves of it, and you could talk to Tina more about it. But again, you got to remember that if it is positive for a polyp, you would have to go through a colonoscopy anyway to have it removed. There are other upcoming tests looking for evidence of cancer, not polyps. That would be like the DNA testing. And those who are gun-shy still of colonoscopy, fecal occult blood testing is also something that is recommended by the task force. And this also reduces the incidence of colon cancer only because if once someone is positive, maybe then you get a chance to oblige them to go through the more gold standard test, which would be the colonoscopy, to have the proper evaluation to see if you just have a polyp or you actually have a cancer, which is still in the treatable stage. So wrapping up with a cartoon over here, just looking at the gender spread in this population, you can say it's the women who are typically taking the proactive role in pushing both themselves and the family towards preventive health care. So here's a lady said, since you only got a few more days for your health care benefits for this year, I'm going to call and see if I can get you in for a colonoscopy. And that is a typical male response. So I'm going to see if I can cut off the phone line. So before your spouses cut off the phone line, let's have Tina come and give us a few pointers on how best to make this a feasible evaluation for you when you have GI disorders.
Good evening. Well, I've certainly learned a lot today. I've seen more about people's insides than I ever thought I would. What your best bet to do is, even if you don't see Dr. Sanjeevi or Dr. Ross, see somebody. If you have any issues, any complaints, any just inklings that something's not right, go with your gut. You have to be seen, you have to be tested. See your PCPs, see your primary care providers. They'll get you your authorizations that you need. And if you don't, there's an appeal process. We're here to work for you. We're here to help you. If there's any problems at all, you call us. You call your doctor's offices. We're here for you. But it's very, very important that you all take care of yourselves. And this is the first step.
Fourth, and we'll open up with the Q&A now with any other questions. I know you've got another one. But please identify which person it's for so we know. Dr. Sanjeevi?
So the question is, does dry mouth syndrome have anything to do with indigestion? More likely, this is something that may require a rheumatological evaluation. I think the evaluation is best started with the primary care doctor. There could be, again, multiple reasons. There may be a lower production of saliva, but also reflux disease, and as we talked about the supraesophageal presentation, when you have reflux long enough and that you're not sensing the acid reflux coming up, you could have the effects reaching up to your dental health, having altered taste, bad breath, and a dry mouth syndrome. Those are the possibilities too. Given reflux is a more common condition, I would definitely consider that as a possibility, and if it is not the case on investigation, it may require a rheumatologist to take a look to see if there is actually a low production of saliva.
That's a great question. So can we live without the gallbladder? The gallbladder, what it does, the entire function of the gallbladder is to store bile. Bile is being produced by the liver, then it goes into the gallbladder. It just sits there until you eat some fatty food. You eat the whole thing of French fries, the gallbladder gets in order to contract and release a whole bolus of bile that allows the body to digest the fat. If you don't have that bolus of bile, but instead it just go drip, drip, drip into the small bowel, what you end up with, and you suddenly eat, so if you don't eat a lot of fat, if you have a low-fat diet, you'll be just fine. Everything is going to be normal. But if you eat a high content of fat in your meal, what you will have, and you don't have that bolus of bile, you'll have a little bit of loose stool, because a lot of that fat will go in the stool, can't be absorbed, that's great. You know, I would have my gallbladder out now. But you know what I mean? There's no disaster that is happening if you don't have the gallbladder. And usually you may have, some patients are known to have gallstones, but have no symptoms. We don't go and take their gallbladder out, because they may never develop symptoms. It's only with the first acute attack. If you have the first acute attack, that's the symptom, that's the evidence that you're going to get more. So it doesn't matter if somebody tells you, oh, you have gallstones. If you didn't suffer from any consequence of having gallstones, your gallbladder should stay in place.
That's a great question. Can stress cause esophageal ulcer? So stress can aggravate any underlying medical condition, but stress by itself should not be the sole cause of any medical condition that you may have. The perceived intensity of the disease may be more given that you're handling stress. You may have more acid reflux than normal, but you cannot blame stress alone as a cause for acid reflux. So again, in situations when the stressor is not there and the symptoms are still going on, you will have to have it evaluated. And I think just wondering if this is stress or not stress itself is a source of stress. So I think a proper evaluation will probably be much more of a de-stressor than wondering for a long time, could it be just me and am I thinking all this up? So the first question from Dr. Saujanya was if the prevalence of acid reflux disease is quite common, and by raise of hands, we could easily tell there are a lot of people in a given chunk of audience that they are on acid reflux. So do everybody need to have this evaluation? One thing we can say is when we meet someone in endoscopic evaluation who have a problem, and we do land up identifying some very severe complications of gastroesophageal reflux disease, be it strictures that require multiple dilation every week, or be it precancerous changes or frank cancer. If you question them, most of them have been putting up with reflux for a very long time, as they have been putting up with many other things in life, so they take heartburn along with it, and they are not seeking help because it's assumed it's just an inconvenience that happens, and it's natural to get heartburn and increasing incidence of reflux as you get older, which is not a case. You should not have to get increasing incidence of reflux just because you're getting older, and I think it's definitely very wise to seek care to find out what kind of reflux disease you have, at least with one endoscopic evaluation to start with, to decide what type of downstream damage you are having. We see people who are very minimally symptomatic with just occasional acid reflux. You go in there, they have a frank cancer. On the other hand, we have someone who's complaining, my esophagus is on fire, it's on flame, I'm having so much symptoms. You go in there, it looks perfectly normal. Everything looks great. So what I describe is there are a lot of people who are viscerally more sensitive. It does not diminish that they're not suffering from acid reflux or the spectrum of reflux-induced disease, but the symptoms do not always go hand in hand with the severity of your disease. So it's best with very safe, easily doable procedures to just get a first-hand information of what you're dealing with, come up with a strategy, and then you do not perhaps need very intense surveillance after that. After we find out what's going on, we can come up with a strategy at what frequency we need to keep looking at this esophagus, and who would be the right candidate for more definitive surgical therapy. So I would definitely say if you have an issue, don't push it under the carpet, try and find out what's going on.
Well, I do agree with the first part of the answer. And what I mean by that, definitely get checked. Don't let your primary physician say, oh, let me just put you on this medication. It's a great medication, you'll feel great. And the reason why there were magic pills, because your symptoms much improved. So you thought, well, I'm being treated, right? Not. And so what I would suggest, and you know, some people get heartburn here and there, like whenever I go to conferences, for some reason people think that everybody should go to a steakhouse. Well, one time I went with Chris, but I don't eat steak, unless I'm pregnant, I don't eat red meat. And the only reason why I would eat red meat is for the baby, because it's just fattening. It's really, really fattening, and it's not worth it. I have 4 kids, 4 pregnancies, trust me, I do not want to gain weight. Right? So you have to watch, and I hate exercise, I don't like to sweat. So you have to control what you're eating, right? And so I went there, and somebody obviously ordered steak. And I just happened to go to the ladies' room, and I saw something that I probably was not supposed to see. But by the way, and when I asked more questions, I realized that, did you know that they actually season the meat with lard, right? It sits with lard. And then when they cook it, and as it's sizzling, it's a whole scoop of butter right on top of the sizzling. And after it completely melted, then they bring it to you. I have a rule when I go to restaurants: if it tastes too good, don't eat it. Don't eat it. It's not worth it, because you end up with reflux. So if you have it just once a week or once a month, not necessarily have to do. Just take that one pill, and that's it when you do have it. But if you have it twice a week and more, Something needs to be done. And if you find yourself having to take those medications chronically, it was not approved for more than 2 weeks by the FDA. Don't do it. Be evaluated for surgery and get it treated and cured. The only real cure for that is not suppressing the acid for majority of the day, because bile is just as carcinogenic, causing cancer, as acid. You're not suppressing the bile. And if you did not fix that sphincter and it remained relaxed, bile is refluxing. And it causes all those same changes. If you find yourself needing those medications for a prolonged period of time, be evaluated for the reflux. And if they tell you have reflux, get operated upon. You may need no operation other than the endoluminal part, the procedure esophagus, through the mouth. But if you're not a candidate, the laparoscopic single incision is not a big deal, but it stops the progression of the disease because you stop the acid from refluxing. Now, you're not going to develop cancer over 2 years. It takes about 15, 20, 30 years. But you don't want to be there. Then I have to bring your stomach up to your neck. You know, that's no fun to live like that. You'll be surprised. It's no fun. So that question was very good.
We are kind of, to chime into the sentiment, I guess we are kind of moving into the philosophical realm too, but it's not removed from the financial aspect of determining. Now, when you're talking about care of a loved one, you're talking about at any cost. But when it comes to policies, and when you're talking about someone covering for it, there are some terms called cost effectiveness, dollars taken for a single life year saved. You know, if you translate it into layman terms, it might translate into, is it worth putting in the effort to keep you alive a little longer? Would you be more expensive to me if I allow you to have a cancer, or would it be less expensive to me if I put in the dollars to find out if there is a tumor? So these are some practical questions that people discuss, and so I think it brings up a lot of philosophically important questions. But again, I think that's where research is going to be very important to keep up with this effort to find more cost-effective techniques that will effectively identify tumors earlier and earlier, so we can fight this battle against cancers.
One last mention regarding healthcare. With the new healthcare reform, we are specialists that you're not supposed to see unless under special circumstances. So it's going to be harder and harder to get to see us, which is not right.
This is one of the question was, what do you think the utility of allergy testing is in GI health? At this point in time, it is kind of a gray area. There are some situations when you clearly know a certain food is aggravating your symptom. I mean, say for example, in celiac disease, your body definitely reacts towards the gluten, and so removing and eliminating gluten completely from your diet is essentially curative when you have celiac disease. Now the other thing is with irritable bowel syndrome, we are finding that there are certain types of sugars that seem to aggravate your symptoms, and we call it the FODMAPs group, which is fructose, oligosaccharides, certain types of sugars. These are not particularly allergic reactions, like you're having an intense allergic reaction, but these sugars are not well digested in your system, so you have more fermentation byproducts and you're reacting to it. So staying away from it might help. The problem I have with allergy testing is most of these allergy testing is skin testing, where they try to tell what food allergies you have. And the immunoglobulins, that there are 5 different classes of immunoglobulins, and those that act under the skin is totally different from those in the gut. So there may be an overlap, so you may be able to identify, but you may also have a lot of false positives because it's a different set of immunoglobulins. The really good predictable way of telling your truly allergic or intolerance. There's a difference between allergy and intolerance. Allergy is when your immunoglobulins are revving up and they're causing symptoms. And intolerance may be just that you do not have the ability to digest. So lactose intolerance is not an allergy. It's just that you don't have the enzyme to digest your lactose. So that is a totally different situation. But trial and error is very hard, but that is the best way to identify GI allergies. So what is the definition of stupidity? Is trying the same thing repeatedly for better results. So if you're taking a same kind of, you take red wine and you repeatedly get an intense headache, don't plan on having a red wine when you're having a plan for the evening. So it's just not for you. You should have the willingness to give it up. But I'm not sure the allergy testing under the skin is going to be the answer for telling you what your gut is sensitive to.
That's very true. And I can tell you from reflux, we had a few patients that came and they thought that they had atypical symptoms. It wasn't heartburn, but they were coughing. And everybody tells them they have reflux. They might be having reflux. And so the first thing that we send them for is allergies. And their allergy was on the skin, so it didn't show anything. And so we evaluated, they had a little bit of acid, so we did the operation which stopped the coughing. Then a few weeks later, this patient went to a certain restaurant and ate a certain dish there that caused the coughing to come back again. So yeah, she had the problem with acid, but that wasn't the cause of her atypical, which is, it's known to be an atypical symptom of reflux. But it wasn't the reflux. It was an allergy to food, a certain food. So it can be an allergy that you won't find necessarily on the skin test.
So the question is, where do you all begin? You accept that you have reflux disease, so where does it all begin? So, it begins with gathering information to find out what is the cause of your allergy. If you remember those images that I showed, in some situations, it's an allergic esophagitis, not acid reflux-induced esophagitis. In another case, it may be achalasia. So just chronically taking acid suppression is more like pushing the issue under the carpet. You definitely need evaluation. That's where you begin. Find out what is the cause for your problem. Is it a hiatal hernia? Is it eosinophilic esophagitis, which is related to reflux? Is it too tight of a sphincter, which could be, early manifestation of achalasia, which totally requires the opposite surgery of what you get for reflux. So gather your details, and going to see a surgeon, and Dr. Ross would agree, it does not obligate you to go through surgery. Your first step to visit with a surgeon is to educate yourself, to get your details, learn about the surgeon and about the procedure and what the outcomes are, and so first step is finding out and educating yourself, and then you make informed decision rather than refusing to look at something and hoping it'll go away. You would probably begin with your primary care doctor, figure out if you require a referral, or you may have a PPO plan which may allow you to directly seek help, but it would probably be the right order of things is to address the issue with your primary care doctor. So you start with a holistic evaluation and then get channeled to the medical specialist to investigate, and then to see if you would require surgical treatment, or is this something that needs to be managed with a certain medical protocol?
I can tell you that, and I'm sure you won't believe this, but Dr. Sanjeevi and I really agree about the treatment of reflux. But if you ask any other or most other GI doctors, many, not most, it's very close, they'll keep giving you medication. They'll just give you medication, and like I said before, then you have those patients that come back with cancer, and they're like, why? Religiously, I followed the instructions. So it's not just to get a gastroenterologist, like Dr. Sanjeevi, research your physicians. You really, we are not all the same. We all go to medical school, we all go to residencies, but we are not all the same. If you saw the the complications that come to our hospital, to our attention from other places, you would think, my God, did they ever go to residency? You'll be shocked, okay? Be very careful. You have the internet, you can research and learn more than you want to. Educate yourself. The more educated you are about your condition, the better you're going to do. Not necessarily. Some people are born with hiatal hernia, so you can't say no, but majority of people develop it throughout their lives. And you don't see many thin people with hiatal hernia unless they had a trauma or something, motor vehicle accident or something that caused that pressure, that elevated pressure that put an opening in the diaphragm. But usually over time, when people gain weight and, physiologically the intraperitoneal pressure is higher than in the chest, so things that if you gain more weight here, it's being pushed up into the chest, and over time, everyone start to develop some hiatal hernia. Now, majority of the people walk around with at least 2 centimeters of hiatal hernia, and not much symptom. Doesn't need to necessarily be fixed. But if you start to have those symptoms, it's got to be fixed. And unless you really modify the quality of life and your everyday life with diet and exercise and not smoking and all of the good things we know everybody should follow, you will have, if you don't do that, you will get a larger hiatal hernia and more trouble. So for instance, you say, who should have, let's say I need an operation. If I come to your practice, to your clinic, would I get one? Well, we'll have a long discussion. If your BMI is more than 30, we'll have a long discussion about weight loss. And I have a whole diet for you to follow, because we don't want just to take you to the operating room for the sake of doing another operation. The idea to do one operation, the right operation, and with the best outcomes that will last lifelong. Right? I don't want to do recurrences, just like I don't want to do other surgeons' recurrences, but we do. Because you have to really spend time with your patients to teach them and educate them about weight loss, keep bringing them back every 2 months to make sure that not become like all depressed about it, don't want to do anything about it, but help them. What worked, what didn't work, how can we help you lose the weight and get good operation. And trust me, you will do great, but it's a journey. There's no magic pill. It's an operation, but it's worthwhile because you want to invest. The most important investment is in your health. You can't buy health.
Just wanted to add a little bit of physiological information, because hiatal hernia, as common as we see it, everybody's thinking, what is this enigmatic process? How did I land up with this hernia? So the whole pinch valve, the sphincteric mechanism by which the esophagus stays above the diaphragm and the stomach stays below is a very fascinating process. Actually, it's not just one. The reason the acid stays in the stomach and doesn't come up the esophagus is, one, you have the diaphragmatic support and the ligaments around the esophagus. Also, you have the lower esophageal sphincter, which has a certain tone and keeps that valve closed. Now, when you have children with hiatal hernia, it's probably something wrong with the diaphragmatic structure itself and the ligaments, that something's too open that they landed having a hiatal hernia. Now, there are other kids who are still in the maturing process and they may have a lot of reflux as a child, and it gets better when things get mature. But with aging, and as person accumulates more body mass, the reason these hernias occurs because there's a creeping fat in the area between the ligaments that's holding the sphincter together that loosens up the whole process. And that's the stage when someone has the sliding hernias where, acid is refluxing back and forth. And that is your window to actually maybe lose some weight and recreate the natural sphincter that you already have. But if you just let it go and keep having acid reflux, and of course one thing to realize is just acid suppression neutralizes the acid for about 14 to 18 hours a day, not 24 hours a day. So you're still having volume reflux, bile reflux, and acid coming up sometimes in the day, is the esophagus undergoes a process called foreshortening. So you might agree that some of those patients with really bad reflux, the esophagus starts shortening up, and now the stomach starts getting pulled up above the diaphragm. So instead of a sliding hiatal hernia, which is just loose and reflux is coming up, you actually have stomach pulled up above the diaphragm, and you always have acid there, and it's always refluxing up. And these are the patients who are miserable with reflux all the time. And the surgery actually gets technically hard too, the more this has been going on for a very long time. Do you agree?
That's 100%.
How about, can everyone help me give a thank you to the doctors one last time, please? At this point, we'll conclude our question and answer panel. But the doctors are actually going to make themselves available at the back of the room. If there were any additional questions you weren't able to ask, you maybe wanted to ask them a one-on-one question before you leave, they will make themselves available. All of our experts will. And again, I know Dr. Sanjeevi mentioned that a PCP is a great place to start, but if you know your plan accepts it, we are able to book appointments with either one of the doctors in the back of the room if you'd like to do so. Thank you very much for joining us this evening, ladies and gentlemen.